You have a certain skill set which you stick to, but then if you are out of your depth or you're in trouble, you call somebody to give you a hand. The biggest thing you can learn in trauma surgery is when to call for help. And normally you should call for help early. Never wait till it's too late to call for help, because if you have done that, you have missed the boat and the patient is in really, really bad shape. So call for help early. If you don't need it, brilliant. Okay, you don't need the help. You've woken somebody up, that's the worst that can happen. But if you call them too late, you have potentially made a survivable patient into a non-survivable patient. So what are the trauma surgeon basic competencies? Well, I'm going to do this very, very generically. The key thing with a trauma surgeon is you need to have had the exposure to enough trauma pathologies to know eyeball, basically, which one is sick, which one isn't sick, and use all that experience to gauge a variety of parameters. First of all, is does the person need an operation or don't they need an operation? That's the first question a surgeon will ask, okay? Then if they do need an operation, what operation do they need? And once you have decided that, when do they need the operation? How urgently should this operation take place? Now, as you can tell from most of my talks, they're very hard to do. I'm not insulting anybody's intelligence by putting up loads of papers, because I know a screen full of papers I use in class. So please just listen to my thought processes as I go through. Now, the basic competency of all operative trauma surgeons is to stop compressible and non-compressible hemorrhages. Okay, so basically, you need to be able to put a clamp on anything tubular which bleeds, and you need to put sutures or control anything which looks like a pump and bleeds. Okay, so we'll come on to that. So in the thoracic section, what is in the remit of a trauma surgeon? Remember, we operate to patient physiology, we do not operate to patient anatomy. So the first thing that comes into the remit is, how do we get access to the chest? All trauma surgeons must be competent in accessing the chest, whether it be through a left anterolateral, clamshell, median sternotomy, or a variation therewith. You need to be able to access the chest and deal with the problems they have within. Once you get into the chest, one of the fundamental things you have to be able to do is open up the pericardium, know the safe landmarks of the pericardium, medial to the anterior fat pad, and then be able to diagnose a tamponade. And once a tamponade, if it is present, has been diagnosed, locate the defect within the heart, temporarily control it by placing a digit over it, suturing it, or use a variety of the adjuncts as described. The other things you have to be able to do in the chest is to cross-clamp the descending thoracic aorta, and as I tell all of my colleagues, be very, very careful when clamping it, is to make sure you do not avulse the intercostal arteries, because then you put the whole in the aorta, which is a really miserable thing to be able to do. Finally, you have the lung parenchyma, and depending on the location of injuries, it can be managed by a simple non-anatomical wedge resection all the way across to higher control. I am not a fan of the lung twist, because I never believe twisting something on its axis to 180 degrees is a good idea, because what you've actually done is cause severe internal damage of the vein and the artery, and invariably have pulmonary vein, pulmonary artery thrombosis. You've actually given a pneumonectomy to that patient. A lot easier is vascular sling around there, or a sloop, snug it down, and you compress the vessels around the bronchus. Now, if you go into the abdomen is very, very straightforward. People always wonder, well, there's only so much you can do with the abdomen in terms of bleeding. You can have vascular, i.e. main vessel bleeding, or you can have solid organ bleeding. In between there, somewhere you can throw in mesenteric bleeding. But the key structures which get injured in abdominal trauma, especially blood trauma, is spleen and your liver. So trauma surgeons should be able to remove a spleen and be able to deal with liver trauma. And I'm talking the run-of-the-mill liver trauma. I'm not talking grade 5 retrohepatic Ivc injuries, which you'll have some individuals give you loads of stories about how they have done atriocaval shunts and they have a case series of survivors. Sometimes I wonder if that is more work of fiction than fact, because even in the best centres in the world, those kind of injuries carry 80 to 100% mortality. What does seem to work in those, especially if you have the resources, is veno-veno bypass, okay, decompressing the retrohepatic IVC. Obviously, spleen, I've said, take out the spleen if it's problems. And then also, what we need to be able to do is identify each of the zones which are injured. Zone 1, 2, and 3. So a trauma surgeon should know how to deal with each one of these zonal injuries and actually, if not repair, temporize until help comes. So these are the major vascular injuries, okay? Then we move on to the actual mechanism of injury. You have deceleration injuries, which occur in the body at points of fixation versus mobility, and they occur at these locations: falciform ligament, hepatic vein, splenic island, basically tail of the pancreas, terminal ileum, as well as the sigmoid colon. Ligament of trite, sorry, I forgot to mention on there as well. These are all points where you go from fixed to mobile, and a deceleration injury can cause avulsion. So, any evidence of blood or fluid in the abdomen, in the absence of solid organ injury, you must assume that there is either a mesenteric injury, and I'll tell you what, I have a really low threshold to have a look. Vascular problems. What does the trauma surgeon? What are the vascular competencies? I would say right as the most basic competency of vascular trauma surgeon is to shunt vessels, okay? If you can't repair them, shunt them. And I think this is, if you're not comfortable with doing vascular repairs, which if you aren't doing them on a regular basis, you shouldn't try, leave it to the vascular surgeons once the patient has got better. And I'm talking about the European model here, but every single trauma surgeon should be able to shunt a vessel. And those who are more comfortable with vascular procedures can do interposition grafts and bypass, either with a synthetic or a reversed vein. Pelvic. What are the key remits within pelvic surgery? And I've just put it in one slide here because the actual basic principles remain the same. When you do pre-peritoneal pelvic packing, you're going right down to the back so you can actually tampen out the venous bleeding that occurs. But remember, it does not work for IVF vein injuries. So you can actually do bilateral incisions like this and just pack around the back and just close them up. That could be a pelvic packing, but the same incision can be used to access the iliac vessels, both the iliac artery and the iliac vein. Now, if you have significant pelvic trauma, you may want to go inside the belly and get access it from there, because up to anywhere between 50 to 80% of major pelvic fractures will have an abdominal injury. So as you can see, a trauma surgeon's remit basically remains, if you think about it, stop the floods, okay? We have to be able to stop the bleeding, and that occurs in a whole array of vessels, regardless of where you practice, whether it be in the UK, mainland Europe, USA, South America, Canada, whatever. Those basic principles are the same. We operate to time-critical disease processes, I will just say. So the geography of where you are located should dictate what your skill set is. And if you do not have this skill set, then you shouldn't be calling yourself a trauma surgeon. You should actually just be a general surgeon. If you can't do this regularly, you can't do this. So, as to remit, if you are not undertaking these regularly, then you are a general surgeon, not a trauma surgeon. So, those are the basic skills, just in a 6-minute overview of what you should be able to do. Thank you for your time.
Unfortunately, Dr. Khan couldn't be here to answer questions and due to clinical duties. Are there any questions from the floor right now? Or we're going to move on and we're going to come back and talk about this topic in the discussion. Okay. Let's move on with the next presenter, Dr. Colcian from Spain, who's going to talk about clinical skills and essential aspect of trauma team training.
Well, thanks again, Carl, for the opportunity and to organize the committee. They're doing a great job. So I want to speak briefly about the non-technical skills for trauma surgeon and for the general surgeon as well. I have no, like I said yesterday, no related conflicts with this topic or presentation. So as we know, group resource management or crisis resource management, really it's nothing new. It's part of the industry, high-risk industry. It's been clearly exposed in civil aviation, also in offshore oil mining, and also nuclear generating plants. So it is high-risk technology, high-risk industries that need to use protocols to train their personnel, because the risk of having an accident would have catastrophic, I would say, results. So they need to train on how to avoid accidents and how to manage themselves in a high-stress situation. And surgery is a high-stress situation, and so is trauma surgery. So when we look at the numbers, at least 10 to 15% of the patients that are admitted to a hospital can have an adverse event. And these adverse events have no relation with their cause or their illness. It's more frequent than others. It's the treatment that we deliver or the necessary procedures that we have to perform with the patient. So the other thing that's very interesting is, as surgeons, we're in high risk because most of these patients that have adverse events are in the surgical world, and half of them are in the OR. So OR, surgery, anesthetist, or endovascular procedures, high risk and medical procedures, because the patient's not well and because the procedures have complexity. So what we try to do with these procedures is the same that they do in the aviation and they do in this high-risk situation, is to use a checklist. The checklist is a way to try to minimize the risk of having morbidity and adverse events. And it's not just a tick box reminder or a simple procedure that we must do, like a routine. We must really stop and think. And at first I was a little bit skeptic with this, but now in our department, it really, at least the one thing that I can say is that it helped us get focused on the patient safety and the procedure we're going to do. And all the team members are on the same page. So that way we try to avoid distractions and try to avoid missing any key steps during the procedure. So as we can see here, this non-technical skills in surgery and non-technical skill education or training has exponentially been growing in the last years. This was maybe 10 years ago. There was even any papers out there, maybe 1-2 papers a year. And maybe in the last 5 years, especially in the last couple of years, as you can see, there's an exponential growth of importance and of published papers. This is a search I performed yesterday, and you can see how in the last year, there is more material being published and there's more expertise, because we're becoming aware of the importance of this, and I think we should keep it in mind. So basically what it is have the 4 skills that we should all surgeons, trauma surgeons, nuclear surgeons, and vascular surgeons have is situational awareness, it's decision making, leadership, and communication and teamwork. I think these are key things, and when we say it like only in words, we don't understand. I mean, it's like something very abstract. But this is a good example of lack of situational awareness, and we'll see how graphic this is and the importance that it has. So this is very Spanish, as you can see. And in seconds, the person that's being taken a photograph wasn't aware of the danger which he was. So you have to maintain situational awareness constantly. So this happened in my region. We're in Aragon. It's in the northern part of Spain, really close to the Pyrenees in the mountains. And this is our I would say, our distance from a helicopter transport to the hospital. We cover about, in 20, 30 minutes, we can cover the whole region. All these patients with severe trauma will go to Zaragoza. But unfortunately, as we know, helicopter transfer is not always available. It depends if it's in the night, if it's in the day. It'll depend on atmospheric conditions, and you know that very well here in Sweden because there's a lot of cold. So the chopper can always go out, but you must maintain that distance. So what we were trying to do in Zaragoza is through the CIVA, is our Center for Education and Training, is to try to create systems to cross-train general surgeons and vascular teams to have at least that basic skill set, because these patients are going to arrive to one of these hospitals, and the best way to do it is, this is a clear example with a friend, a vascular friend, Dr. Irene Soler from the Miguel Servet Hospital, is the biggest hospital in my region, and we do cross-training with swine model. And it's not only robotic technique, but also open vascular technique, doing a patch, trying to do an access, trying to do a shunt. So this is our concept that we're trying to push forward with the support of the SIVA. This would be the main reference hospital when you do have all the vascular capacity to do the complex procedures. And this is just a couple of cases. This was a case, a young guy, as you can see, his feet, the distal foot is ischemic. He got his foot grinded basically by a concrete mixer with a nasty wound. It was fixed. He had external fixation and popliteal revascularization with saphenous vein. This is procedure that's not done by me or my surgeons, but it's done by the vascular team. This is another case. We also had this patient come in, intubated from another hospital, and they performed a two-step procedure. One was to revascularize upper extremity, and then to do a sural nerve implantation because the patient had lesions also to the brachial plexus. So this is just an example. So in summary, what we want to do is we want to train as a team. Not individually. I think that's good about that concept that we have here, that there's no ego, and I think that's very important. Like Mansour said, know your limitations. If you're not a vascular surgeon, just get the patient to a vascular surgeon, to a vascular team. It is really important to brief and debrief each case, because with each case you can learn something new. Prepare for the unexpected, and prepare for the unexpected, because their patients always are full of surprises. Call for help early, but you must also remember that not everybody's going to be immediately available. And like they said in the prior presentation, you have to know your limitations and work your way around them. You have to do something for the patient. So in the end, thank you so much, Tal. Great meeting, and I'll be open to questions.
Thank you, Paul. It's a great talk and an important topic, especially nowadays when the working hours limits how many cases attending in a residency, and of course with the centralization. When we talk about the training, team training, do you have your nurses, your anesthesiologists, and those as well in those trainings, or is it just for surgeons?
Yeah, that's a great question. So because sorry, Shaheen, because what we're trying to do is there are several things that are important in the department, in the SIVA, and what the concept is that first the training has to be available for all the surgeons of the region, not only for my hospital, all the hospitals of the system. Our system is called the SALU. It covers the whole region. So first, they have to be available to all the surgeons, but also not only surgeons, vascular surgeons, anesthetists, and general surgeons. The second, it has to be, it's free. It's no cost. It's the program that's funded by the system, by the hospital, and all the instructors and all the people that develop courses in that platform are doing it free of charge, right? So the idea is to improve the system and try to build the system from the bottom up. I made a couple of changes in my presentation that I could not include because of the time. But it is important that when we do this cross-training, we try to, like you said, get anesthetists, blood bank is also very important, and massive transfusion protocols, and also interventional radiology. So it's like a multidisciplinary task to get everybody involved.
Comment regarding the last presentations. I completely agree with him. Because in the last 30 years almost, we have been trying to cope with a model of trauma surgery and systems that are not applicable at our latitude. Now I can Italy, Europe in general, maybe even South America, and even some part of the East. Because the general surgeons, as Mansour Khan told us, yes, in Europe we have general surgeons, we are not trauma surgeons, because we have emergency general surgeons that face the different situation, from the appendicitis to the trauma. So a completely different case exposure, a completely different formation needed. But the point is that the formation and the meetings are not only at the surgeon level. As Carlos told us, we need an equipe formation for a different system, based on the case exposure of the different groups, because it's time to speak about different systems and different kind of surgeons, because the trauma surgeon is done in the United States. It's impossible to apply at our latitude. We have no penetrating injuries. We have completely different kind of case mix. So no possibility to apply the same system. We have to develop proper case in mix in order to have the patient gains from the mixing.
I totally agree with that comment, and I just want to echo once again. Most of trauma centers around the world that are basic emergency surgeons doing trauma. There are very few centers that do have that volume that are giving trauma on a daily basis. And another comment I want to make on that question is that most of these cases, even for the vascular surgeons or for the trauma surgeons, it is about the anatomy. So basically, it's the difference between the elective carotid and coming in with the gunshot wound that has taken half a minute and there is no landmarks or stuff like that. With the peak training, I think it's great we have it here in the program here in Norway as well. And with the warm lab cadavers, and our colleagues from the United States are not here right now, but there are a couple of centers that have started with that. And I think that's the best thing, to have the human anatomy. What are the perspectives on that in Europe, and can we ever get there?
Well, I'll talk from my perspective. I don't know Federico, but in the US, I think it's a bit easier because, well, at least I know in LA with the Dr. Demetriadis, they have an excellent lab, and you can also do cadaveric dissections, and also the acid course is a very, very good course. But we don't have that much availability of at least of fresh cadaver material to be able to do that. We can, through the university, have and anatomy department, have some availability to try to do some, it's more like workshops. I don't know if it is possible, we have to work on that, but for now, the PIC model gives us a good basic training to do basic techniques, but I agree with you, the anatomy is completely different, especially in the neck and in the inguinal region, because the abdomen, it is what it is, but the neck and the inguinal region are key, and we would have to go towards that model.
Thank you, Carlos. Moving on with Dr. Buffer, I think he's on Zoom. Dr. Buffer doesn't need any presentation. He's a giant in trauma surgery. He's going to talk about endovascular training in surgical residency. Should it be done and how?
Am I muted or can you hear me? No, you can hear me and should be able to see me. Okay, slides are up, okay. We don't have a picture of EVTM. All right, I'm listening to the other talks. I'm going to say more of pretty much the same thing. The reality is that in 2021, I haven't got the slightest idea of how it should be done. We know that the treatment of vascular injury is either to stop the bleeding or restore the circulation, or both. Well, that's all well and good, but what do I, as a non-vascular surgeon, do next? Because there's a zillion opportunities, none of which is necessarily attractive. Lack of a plan should not, but generally does, constitute a crisis. This is taken in East Africa. I don't know who's at fault, the pilot with the giraffe, but I do know that both the patient and the surgeon suffered. So you can plan to a certain amount, and so you can't that the military is a comment that failed to plan to fail. Well and good. The reality in 2021 is general trainees are underexposed, both in terms of adequate training and absolutely in terms of adequate experience with the crises that we're dealing with. In addition to that, specialist trainees, particularly in vascular, cardiothoracics, and so on, have the difficulty of being reduced to helplessness because that's not a main area of interest for training. Also, there is a lot of limitations in places like the United Kingdom, for example, which drives things. Our American colleagues will tell you that in South Africa, for the same reason, and in the United States, we get about 25,000 hours of training as a trainee. And that is actually more than enough for expertise to be developed in high volume centers. Having spent the last 5 or 6 years of my life working in Sogoretska Hospital in Gothenburg, this is the European situation. Almost 2/3 less training. The solution to that is unfortunately obvious. Most European training is reducing the general exposure to 1 year and increases the specialty time to 4 years. The result, unless you're an emergency general surgeon, you have limited general experience. If you're a general surgeon doing emergency work, you have no vascular experience, and that which you've seen is probably the very focused stuff, EVAR, done by vascular surgeons. That is the reality. So here is the vascular surgeon dealing with a trauma patient. Why? Well, because they're used to doing things through scopes and whatever else, and the open bleeding trauma patient, or the patient who needs things like Roboa, that's not in their normal domain. The general surgeon feels exactly the same way about vascular. And in Europe, in 2021, who is the general surgeon? Even the emergency surgeon is specialized in emergency techniques. I would not want an emergency surgeon to do my Whipple's procedure, and I'm not sure I would want an emergency surgeon to be doing my EVAR. So is it the trauma surgeon or is it the vascular surgeon? Well, to give you an example, in South Africa, we have 1,500 surgeons for a population of 60 million. The numbers are there, but the reality is 60% of general surgeons do not work in academic centers. They're in rural and urban smaller hospitals, none of which have got the funds for any vascular equipment, let alone EVAR or Roboa. I always remain a healthy skeptic of a really good technique used inappropriately in a wrong situation will bring the technique into disrepute. So where is Roboa based? Pre-hospital certainly has a huge indication there, but then doctors working in the main hospitals don't get that. Emergency department, by time, perhaps. Operating room, yes. Where? And which conditions? I would submit that the biggest fault that we have is in 2021, we treat everything except bleeding, factors 1 to 13. I challenge you, the commonest cause of bleeding is factor 14 deficiency. So the trauma surgeon knows the anatomy, can access the chest, definitely used to uncontrolled surgeries for trauma, definitely used to uncontrolled bleeding, but is not generally present in Europe, maybe except Germany, maybe except Austria, and does not know EVAR. The general surgeon does not know vascular surgery, has limited ability to do vascular surgery, although they can probably do most general stuff, but it's a dying breed in the European environment. And the vascular surgeon is not used to uncontrolled surgery. They hate it. They're well experienced, but the reality is no one is trained. And on top of that, we're trained that perfection is the enemy of good. So it's all very well to say, choose the surgery, choose the surgeon. But I would submit that in 2021, in Europe, there is no one surgeon. You're looking at a surgical team. How do you train the surgical team? Good judgment comes from experience. Experience comes from bad judgment. And there are too many cases of bad judgment where trying to be perfect has destroyed it. It doesn't matter who does the surgery. You've just had the acid course mentioned. I am very much part of every surgical training. DSTC teaches this. You need to be sufficiently experienced, but not too proud to ask for help. There is no one solution. But I submit, and I'm very happy to be shot down, the trauma surgeon of the European future may be a vascular trained surgeon with some general surgery background. Thank you very much indeed. And I congratulate the organizers of the trial and the EVTM for a spectacular congress yet again. Thank you.
Thank you, Dr. Butler. As always, an amazing talk. But it raises some questions for giving us the answers, sir. So I'm going to start with the unpopular and politically wrong questions. Actually, there are two questions. Should we go back to the old days that we do the 80, 120 hours training? Because obviously you show the American numbers with 25,000 hours and being partly training in the United States, I can say with the administrative, that number comes down to like 12,000, 15,000 maybe. That's my first question. And the second question is that, and this is also for our surgical and vascular surgeons here, that with the progress of the field of endovascular surgery, basically what you learned last year is out of the toolbox this year. Is there any chance that we can train trauma surgeons or general surgeons in vascular surgery who are not doing vascular cases electively on a regular basis? Because next time they are in the lab, those things they're asking for, they are not on the shelf anymore. Thank you, sir.
I think they're great questions. The first is, as you get older, you live in the past. I really don't see surgery returning to being a 24-hour occupation for anyone. With lifestyle changes, certainly in South Africa, in my department, we have more than 50% female surgeons. But if you look at many countries, that's about 5%. Unless you can balance, and anyone under the age of 40 insists on that, unless you balance the lifestyle with your career, it's extremely difficult for most people. So I don't ever see us going back to the multiple intensive hours of training. America may be very different. The second thing is that with the area of super specializations, and you know, in Britain there's an expression, oh, you're a general surgeon, weren't you good enough to specialize? So I think the reality of super specialization is here and going to stay. Therefore, we have no choice to accept that there is surgical apartheid. There is surgical separation into first world countries which can afford super specialization and developing countries which frankly cannot afford any of the stuff that was done 5, 10, 20 years ago. And as you correctly say, every year brings a new EVA or new technique. The only way we can do it is what Sweet's been very good at, and that is global surgery, where the techniques that are necessary, particularly in trauma, can only really be studied in developing countries. It's a tripod. You need patience, you need teaching expertise, and you need the resources. And there are very few countries that can actually fulfill that now. So I don't have the answer, but I think if you don't make use of the resources outside of your country, then you're going to rob from and detract from the resources in your country.
Dr. Kessel?
Yeah, good morning. I have also a question to Dr. Bafra. You know, as here in Israel, we have the same problem. On one side, we do more endovascular, less operating. From the second side, we cry that no enough surgical exposure to general surgeons. What is the solution? And when I hear about Europe, my question is, who is the trauma surgeon? Just one that does something that nobody wants to do? What is the indication of trauma surgeon in Europe? Maybe it should be pass any accreditation. For example, in Israel, it's no chance that the chief of trauma unit not does a formal fellowship for 2 years. Maybe the solution is to define trauma surgeon as someone which in mandatory way goes through 2 or 3 years or formal fellowship in a high-level trauma hospital?
I agree to a point. Firstly, in South Africa, you do a general surgical training for 5 years or 6 years. You then do 2 years of dedicated trauma surgery and intensive care. Because I don't believe a valid trauma surgeon is anyone who does not understand, not necessarily do, but understand intensive care. What we're seeing in Sweden and in Norway is a move to split hospitals. And I know I'm on very, very dangerous ground here because there's a lot of people from Karolinska. But Karolinska is now 2 hospitals, Sweden and Solna, with different disciplines in different hospitals. So now, does the surgeon move to the other hospital or does the patient move to the other hospital? It's a bit of both. I think the reality is in Europe, it's past the point of no return. So one has to say, we are where we are. What could we do to enhance what we have if we have an interest? Preserve our lifestyle. And the answer is the United States, South Africa, a couple of other countries who can provide intensive training for a short period of time. I don't see any other way of doing it.
Absolutely agree. And the second short question is, you know, what kills people with abdominal trauma? Liver injury and abdominal vascular trauma, most. So who mostly deal with abdominal vascular trauma? Do any vascular surgeons have experience with abdominal vascular injury? So where needs to do it? Trauma surgery or vascular surgery?
That's a great question.
I would argue that with that very briefly and say you don't die of a liver injury or your vascular injury, you die of the bleeding from either. And so what you need is someone capable of stopping the bleeding. Once you stop the bleeding and once you're capable of shunting, and I really do believe every general surgeon should be capable of pressing on something, source control. Every abdominal surgeon should be capable of that. If you can buy yourself time, you can either get help to you or you can get help, you can get the patient to help. But if we don't have the expertise to stop that bleeding, no matter where it's coming from, and to restore the circulation of that which is distal, then we've lost the plot.
Thank you. That's a
Thank you.
good question and great answer, Dr. Bakker. We're going to move on with the next presenter, who's going to present the junior point of view, David McReady, who is working with us here in Örebro, and I don't know how long we can call you the junior, David.
Thank you, Joy. So my task now is to present me as a vascular surgery resident, my point of view of how the future trauma surgeon or future vascular trauma surgeon should be trained. So residency programs have been going on for a long time. They started back in Germany, the end of the 1800s, but it has changed a lot over the past years. We've got new technologies that have come into the systems, which have changed the way we do surgery and our approach to both general and vascular surgery. And this has, in many ways, decreased the surgical opportunities for residents to participate, especially in those patients that are mostly injured. This is one of the new technologies is the use of CTs. Now we basically do CT on every single patient that comes into the emergency room. And what happens here is then that we now more and more also treat patients conservatively. Also the use of ultrasound to detect different sources of damage. This is especially noticeable in countries, for example, in Europe, where the majority of trauma is blunt trauma. In the US, it'll be slightly different with more penetrating. We can also see this within vascular surgery, with the use of more endovascular techniques, doing more complicated fenestrated endovascular repairs. This means that open surgical exposure of, like we've been speaking about, at the aorta and allowing residents to practice these types of techniques have been diminished over the years. And here you can see a slide of how the prediction of within America, what they predict exposure for residents will be in the future. There's also been restrictions to how residents can work. We have restrictions within working hours. Previously, there were no restrictions, and therefore residents could be in the hospital. That's where the name comes from, resident. You basically lived in the hospital, and that's in that way you were exposed to more surgery. But this has also then diminished the amount of surgery that we can be exposed to. And also, this has been mentioned by Dr. Boffa just recently, that also lifestyle changes. People now, with younger generations coming through, don't want to just be working all the time. A lot of people want to have families, and they find that trauma surgery or general surgery is a very demanding and stressful specialty, and people will go into other types of medicine. And this is not something just for doctors. We see this in other types of professions. And then specifically within surgery, you can see that using residents basically to staff the ER, general surgery or trauma surgery, it becomes more of a non-operative or a babysitting role. So how do we fix this problem? Well, we spoke a lot about in previous sessions that don't perform unnecessary surgery, and I completely agree with that. We shouldn't be doing procedures on patients just to be practicing them. We should be doing the best for the patient. That's the most important. But what we need is formalized and structured curriculums for us residents, so we get through all stages and we make sure that we learn what we're supposed to know when we're finished. And this can be done in multiple different ways. For example, increased use of both cadavers and simulator training. We can also use different types of workshops. The EVTM workshop is, for example, a very good way for practicing multiple different types of procedures, but we need specific workshops for residents. Also, it's important that workshops, when you don't attend a specific workshop only once, I believe very much that you need to attend these workshops several times, because being a young resident and learning a complicated or a way how to do a splenectomy, for example, if you go back to your hospital, you won't feel comfortable doing that. You need to practice. You need to do it multiple times. And also, for example, like the EVTM workshop, where you have multiple different specialties, I think that's very important, because even as a resident, we can learn from each other. I can teach a general surgeon at the course how to puncture an artery, but they can teach me how to sew the valve. I also believe that we need more international collaboration between different societies. So all separate societies have their residential or younger parts of them, but we need to collaborate because we can learn from each other. And also to include residents in, for example, meetings like this, scientific programs, so residents can learn from the most experienced people at these types of congresses. And also have not just specific sessions for residents, but actually include them into the main sessions so people actually come and listen to them. For example, Estes have regular webinars online every week, but the problem with these is it is mainly the most experienced people speaking about them, discussing between each other. And for a young resident who's maybe not that confident in asking questions or making statements, it's quite difficult to enter into these types of discussions. I believe that what we need is a type of resident type of webinar where we have certain attendees and people with a lot of experience, where we can, for example, present cases and have discussions, but we have this on an international level and learn from each other in different centers. Thank you very much.
An excellent talk and many good points to take into consideration, especially with the organizations to collaborate more and have residents more involved in the education. Are there any questions from the audience or?
Yeah, excellent talk, David. I think you made a good point. I think all the activities should be oriented to have a high participation rate of residents. A comment and a question. I think international cooperation is key, and especially among European countries and among different organizations. Did you guys have in Peru some type of international or funding program for young residents to be able to go outside and do part of their training? And I think that's key also to give them a hand economically, not only with learning.
Yeah, that's a great point. I mean, I think that we specifically in our group, we have opportunities to go to different centers, but I think that there's different centers will have different economic possibilities of sending their residents to places around the world to be able to learn certain types of techniques, to be able to send them to these expensive courses. But I think that we also need to start looking at this on a more international level, because we need to have a collaboration. These courses are becoming more and more expensive, and for Western countries that might not be as much of a problem, but we will have other countries that don't have the same economic possibility of sending. So we need to help each other in a different way.
If I may comment, brief comment. The point is that I agree with everything you said regarding the international collaboration, necessity for people to go around and see and to mix up with other people from other countries. But in my opinion, the very starting point should be that the seniors, and I am inside for everybody inside here is among the seniors, provide not a big amount of hours for residents, but a quality amount of hours for residents. Because in each reality, and we all know, but nobody can tell, many residents are inside without doing nothing. They are not motivated and they are frustrated. So the main point at the beginning is to change the single realities, and then, yes, mixing and having institutional and international exchanging programs. But the point is that we need and we must, because in my opinion, the teaching and the research is an ethical issue inside the medical activity. We cannot detach the medical research and teachings to youngest and to the other colleagues from the medical activity. So it's an ethical also issue that we must focus on, because it's a mandatory point. This is.
Yeah, that's a great
David.
point.
David.
Yes.
Yes.
Yeah, good morning. My answer to Federico is key to resolve this problem, Federico. Just to choose right people, high quality residents. If you have high quality residents, you will have no such problems. But I completely agree, David, with your way, and I think it's the only simple way to do things. Yeah. Today in the Zoom days, what not to organize international clubs discussions, technical supports, case reports, and so on. So a lot of things to do. You know, in Israel, will take one more minute. We have experience with surgical trauma forum, which is organized every 2 weeks. And unfortunately, I have a bad experience with this. Why? Because in next 10 seconds, nobody of residents cannot talk, cannot say his opinion at all. The senior starts arguing with each other, and the people finish the speaking a little bit confused. You have to organize a surgical residence or fellow forums with local chief of trauma and one or two senior trauma people, and that's all. You can organize multiple courses with the European privilege of single license. Yeah, in Europe, you don't need to have any other license to move to Italy or Germany or other countries. And workshops or courses just to do exchanges of courses. Some people come into Oregon, maybe free of money to a reward course, and someone goes to a high volume German trauma center for 2 weeks, for example. But I completely agree and support these days, in my opinion, is a single way to go.
I completely agree.
Dr. Planning.
As you know, we've got lots of exchange programs in South Africa, and on top of that, we've also got a very open, great initiative. The Mill Park Hospital, and soon hopefully the Union Hospital as well, the Mill Park Hospital, sit in the way of our open M&Ms and teaching opportunities for basically every month. And people attend from all over the world just to see what M&Ms and clinical discussion are at the center of our volumes. But maybe it's a matter of finding out Swedes, Italians, Finns, Spaniards will be coming to Sunnybury Health Academic Hospital and John's Academic Hospital for many, many years. And they really go back to the local context. The other solution, obviously, that's an issue I thought was quite funny. North Shore, Royal North Shore in Sydney, the 10 residents, 10 surgical residents on call. One was for endocrine, one was for abscesses, one was in case of breast emergency, which all sounds absurd. But if you look at people that are not really very well trained in lots of stuff, but you've got enough people, then you can, in order to obviate the needs of working longer hours, you can just make sure you've got lots of people on call, and whenever you need anything which is not really competent, you call somebody else that does that as a subspecialty. I don't know whether it's realistic or not. It's also another way of utilizing everybody that's got specific subspecialist training. Thank you.
Great points, Dr. Planning. Okay, moving on to the next presenter, Dr. Federico Coccolini from Italy. Trauma and Surgical Registry, important tools for research.
Thank you again for the invitation for this meeting. I would like to present this project that is going on since a few years. In the beta phase now, it reached the definitive phase. I have no conflict of interest. The point is, which is the acceptable mortality? Mortality is a strong indicator, but you can translate mortality in any other outcome. Which is acceptable mortality in emergency trauma surgery? In the different countries, in the different world region, even inside the different region of the same country. We don't know, because we have no enough numbers to evaluate the indicators to define the acceptable rate of something. Because different situation, different settings, different country, different regions has different systems, completely different. And so we have no, at present, the possibility to compare the results. For trauma surgery, we learned a lot of numbers from the United States, and then from Germany, that established an organized trauma system, and then from the other countries with a sort of spot results around the country, but without any unitary movement within the same nation, in the same country, the same content. Because different human resources, different exposure, different possibility to access to the facilities, to the staffs and everything, may impair the results. So we cannot compare at present, because we need something that can accrue data from all around the world in order to try to have a big numbers, and then to have sort of benchmark indicators for comparing results and for referring our results to the system in which the results are obtained, because different system, different results. The results of trauma in the center of Africa, or in the center of Russia, or in the south of Italy is absolutely different. And the point that the register is needed, because we need evidences, and it's quite impossible to conduct large studies in emergency and trauma surgery. For large, I mean thousands or hundreds of thousands of patients. So we need to share data and results, to have a point in which all data are recruited and then common analysis is done. And then we can even compare and match the different results within different hospitals in the same condition, in order to have even a comparison within the same situation, or almost the same situation, and so to obtain an indicator of which are the real results of the single hospital. 20% of mortality, for example, in a place is not the same than in another place. So we cannot talk about a root percentage or everything in some place. We have to compare to know which that percentage refers to. And then we may be able to elaborate benchmark values and trends to try to improve each single system, and each single system may try to cope with the other single system, asking and obtaining answers regarding the eventual differences and maybe improving differences to be applied inside the single system. This is the all the documental part, the committee approval, all the registration and everything. And the point is that the register will be free, totally free, and each person who participates in the center will have the personal database that is for free and may allow for analysis or for internal evaluation of the system. Even some tools for main analysis will be provided inside the register. We may obtain group data on the effective or on the effects of our work, and all the people who participate inside the registry will be included into publication as author or contributors, depending on the publication. But this will be something that maybe will enhance the participation and will improve the accrual of patients. You will see here the website in which the register will run. Many other registries are running inside the same. At present, with the beta phase, we enrolled a few thousands of patients. So we have a lot of data up to now, but the necessity to increase the number is strict. And this is the mask you will find inside. You can see here that surgical, emergency surgical, and trauma are divided because two branches, two different registers, but inside the personal data bank, you will find everything, and you can extract your patient according to the queries of extraction. And on December 15th, it will be definitive launch, and you will be able to participate and to enroll patients. So, for everybody who would like to participate and to share the invitation, this is the link, this is the website, and it will be totally free now and in the next years, so it will not be paid. Thank you very much.
Thank you, Federico. Great project in process here with the VSCS. So we have 5 minutes left on this session, and I would like to ask a short question, and I would like a short answer so we can go around. And Dr. Hill said plenty, Dr. Popper, where do you see the trauma surgery training go from here? Are we going to get more specialized, or are we going to change the type and have more people doing more of the common emergency surgery?
Right. I think it's as pointed out by Kokolini, basically it's emergency surgery. It's even in South Africa, other than in dedicated trauma units, it's emergency surgery, which includes trauma done by a general surgeon who should have knowledge of trauma. If you do trauma as well as general surgery, automatically you take it upon yourself to know what you're doing. And therefore there should be a need assessment of what you actually need to do as an emergency surgeon that also deals with trauma. What are your needs? And find out how do I fulfill my needs. Because basically an emergency surgeon, most of the time I won't be doing trauma. Even in South Africa, as you saw, there are about 40, but probably only 30 actually practicing trauma surgeons. So, but if you say I'm an emergency surgeon and I'm in charge of trauma, then it means that you actually need to know what you're doing. So you need to find out, do I need to do special courses? Do I need to have a specific time, even in a place with lots of trauma dedicated, in which I go and spend some time in a dedicated trauma unit, until I'm a reasonable emergency surgeon that can do some trauma. And the other thing, obviously, once you've got the basics, once you've got the contacts with the people that do trauma surgery all the time, make sure that you actually contact them all the time. You've got a difficult case on the table, you phone them with a video phone and say, right, I'm in trouble now, you know me, I've trained with you, I did some training with you, what am I supposed to do now? So basically you realize that the patient comes first. The patient's needs come first. And sometimes it's going to be a matter of people that have to slow down, fulfill those needs are not dedicated trauma surgeons, but the need to have an access to trauma surgery we can go. That's my feeling. Thanks.
Thank you. Dr. Tilson?
I think those are some very good points. What I would like to add to that is to say that really we can't turn the clock back. For at least the past 25 years, we've been saying, probably 30, we've been saying that training is getting less, experience is getting less, exposure of training is getting less. I think the time is well past for us to stop saying that and to actually work with what we have. We've seen that, we have a lot of team working. I wouldn't go quite so far as the Australian experience of having, your abscess surgeon, your breast abscess surgeon, your buttock abscess surgeon, and so on all call at the same time. But you do have a lot of people who contribute to your trauma team. Those people who are your vascular surgeons, your general surgeons, your orthopedic surgeons. And what we should do is to be training everybody within that as a team dealing with trauma and getting them involved. And with the experience that we now have with Zoom and other remote forms of communicating with each other, which we've got very used to using over the last 2 years, we really have very little excuse for not talking and contacting other people when we need help and assistance and help in making decisions. We now have to move forwards from the 18th century and the 19th century through into the 21st century, using what we have, the teams that we have, training together, working together as teams, and using the technical resources that we have to be able to supplement that training.
Thank you. Final words, Dr. Buffer?
I would agree entirely with Jonathan, except trauma is changing. And Europe is a particularly good or bad example. The reality is that Europe, for the first time in many, many years, is seeing military trauma in the civilian environment. And I don't have to tell you about bombs in Madrid or high-energy rounds in Paris. The second is that NATO and the military are down to the lowest levels in most countries that they've been since the Cold War started. And the end result is they no longer have military surgeons. They have reserve officers who are civilian surgeons who are completely unfamiliar with the military injuries that you get in combat. And I've got to be careful about, because my hosts are very much Swedes, but those of you who have access to Dr. Google, put in 2 words into Dr. Google, explosions and Sweden, and you will find that in 2019, there were more than 200 bomb blasts in Sweden. Military has come to civil, and civil is going to have to change its mindset to the military. And unless those 2 areas talk to each other and share each other and learn from each other, then I think Europe is doomed to have more mistakes than it wanted. So I think that you've got to accept you're in a global platform, share it and use it.
With that word, I would like to thank the panel and our audience and the collaboration with EVTM and Estes. Thank you, Tal, for inviting us. And thank you, everyone.
May I make a short comment? If you have 2 seconds, just to connect to Dr. Brofa's words. In Israel, for example, my single hospital was exposed to 53 or 54 mass casualty events due to combat. And we have the unique experience how to deal with blast injuries, even primary, secondary, or tertiary, or so on. So, for example, if someone wants to learn from our experience, you always invite. Thank you.
Thank you. I'm honored and fortunate
You're going now?
Yeah. Visited many hospitals in Israel. In fact, it's a disproportionate amount of time in the class, by the way. So thank you, and we look forward to. This is what EVTM is about. It's mutual cooperation between widely different sectors of countries.
Right. Ja, tack. Ja, det blir en förändring i livet. Ja, men det tror jag tror inte det. Man kan säga så här.
for Malmö and Lund to Malmö, and we felt strongly that it was worth the risk and the delay of transporting patients from Lund to Malmö in order to be able to offer them endovascular repair. And that was a drama also, because there were some people who truly hesitated about this, who had true, feeling that this may not be that it was actually dangerous to the patients. That was one aspect. And then, of course, you will encounter this globally, I think. There was also a political dilemma where, of course, there was a political tension. People at the other hospital wanting to keep this type of surgery in their place, etc.
But let me get you back. Just let me be hard on this with everyone. If today you get a rupture, not like in the old days, you're standing there, you communicate with your anesthesiologist. You just put the balloon in, and we're talking in your case, it's vascular and ruptured, etc. But I think it's also for the trauma or the non-stable patients. And would you think otherwise now to think about more on the systolic pressure or mean arterial pressure and being more sorry for mixing Swedish here, but more communicative with your anesthesiologist? What do we have for pressure? Maybe taking down a bit the balloon, changing to the other balloon?
Yeah, so yes, definitely I would communicate continuously with the anesthetist. And I also would ask them to turn one of their multiple screens such that I actually can see the blood pressure from where I stand. And if I had to change balloons or deflate the balloon temporarily and expect a blood pressure drop, then I will communicate that with them. Having said that, I have seen pretty bad complications from the balloons also. So although I'm a great fan, I personally don't use them in any sort of preemptive manner. I usually say, to my best knowledge, they should be used if the patient is actually dying now and then, right there. Then you should inflate the balloon instantly. You should have everything prepared so that you can really do it undelayed.
That's a very nice comment.
I would hesitate inflating it just because the patient is unwell, etc. I think it's a dangerous measure, particularly in the elderly atherosclerotic patients where we have seen complete thrombosis, and dissections and stuff. Recently here in London, we had a complete rupture. I had never seen that before by a coda balloon of the infrarenal, juxtarenal aorta. So it is not completely safe. This balloon rupture was happened to a very experienced colleague of mine, but people who don't have a large experience with the balloons will get even more stressed than the rest of us, and they will probably tend to inflate it more than necessary, harder than necessary. And if the patient that is 80 plus and atherosclerotic, obviously the balloon is capable of rupturing the aorta.
A very good comment, Martin. I remember when we started to do the ruptures, we tended to use the balloon all the time, and then once we learned about the backside, those things that could happen with patients, we started to think more of the physiology of the patient, and that's why we started to use the balloon just exactly those patients that you are referring to. They were about to die, and then they needed a balloon. So what I think we learned from our past lessons with the ruptured aortic aneurysm is that we in the beginning we were very busy learning the technique, putting the stent grafts, balloons, and then the evolutionary part came when we started to think about the physiology of the patient, and that thought of physiology, it continued to the ICU. Most of the times we succeeded in saving the life of the patient in the operating theater, but we lost them in the ICU. So the great work has been done to follow the physiology of the patient in the ICU the first 3 days. That was a very good game changer for us.
I just want to ask if Frank Plani is online. Professor Plani.
Yes, yes.
Yeah, great. Professor Plani, you have a lot of experience in Frank, yeah. And Frank, you have a lot of experience in trauma surgery, in unstable patients, and now with revolves for the last years and other techniques. Do you have any thoughts about the modern use of these two?
Yeah, look at the, as I said, both in Reborn and also with the cheap favorite method, not in Reborn, like putting a string around the water. I mean, we do it, you know, I think it makes a lot of sense to keep it on full Reborn for 15 or 20 minutes on the basis that perhaps it's good hemodynamically and also perhaps some of the, there's more clotting in the area with not food. I don't know, I can't remember a meaningful study showing this more hemostasis. The bottom line that we try to get the buffer all the time and we carry on. And that's why I said that sometimes we carry on for so long that releasing a bit and then taking it up again. That's why in a way it becomes more practical once you're in an abdomen. To actually have a sling around the altar. It's a lot easier to put a robot on the sling and release it a little bit rather than having somebody with the pushing on the syringe in keeping partial report. So, and then we always keep the, in any case, even if we don't do a report, we always keep it actually aligned with femoral artery. So then we can actually monitor, we can actually follow how much pressure, how much blood pressure there is. And obviously being in the abdomen, you can actually feel for yourself with fingers whether there's any flow or not. And sometimes just getting the Doppler in the altar distal to the loop or to the reservoir, you can feel what if there is flow.
So in other words, you're thinking now that, or we're thinking that in other words, we do not just occlude the aorta, we just have to maybe bring the patient into a certain pressure, perfusion, brain and heart pressure, in any means, partial revolve, or if you taught me this with holding with Foley catheter around the aorta, whatever means, and trying to hold the patient until you have some kind of surgical or non-surgical solution of the bleeding.
Yeah,
correct.
And I think sometimes it's actually been irritating. We had some particular placenta, but very, very complicated placenta. And the urologist and the obs and guys would say, oh, well, there's no bleeding, so we can carry on. And sometimes after 3 hours, of doing partial revolt or partial occlusion, intermittent, partial, whatever, we told them, hurry up. We basically been occluding the aorta on and off for 3 hours. And there've been absolutely no problems. I mean, the releases religiously every 15-20 minutes and then start again. But I mean, it really buys a lot of time. And sometimes we really feel that it buys too much time because people don't realize it's actually leading to certain control.
Okay, thank you. Any here in the room, any comments or questions? Any comments on this? Yes.
May I make some comments?
Yes.
You know, there's lots of things we know, but much more we do not know. First, you know, our experience comes from open aortic clamp closure. When you close the aorta surgically, what is the blood pressure that you estimate? We have no idea. Some patients do blood pressure up to 300 mercury in all of us. Saw it, we have experience with, and some patients did not elevate blood pressure more than 80 blood pressure. In my opinion, if patients do not respond to aortic closure with more than 140, 150 mercury, in most cases is an unsalvageable case. You have to see much higher blood pressure than 100 or 120. 80, 70, in my opinion, is unsalvageable case. So maybe the right way to do partial occlusion firstly, and to see how patient responds. If immediately blood pressure upscale of more than 100, 120, you don't need total report. If he doesn't respond immediately, maybe then you go to the total occlusion.
But the question is also how to work. Okay, you did this RIBOA thing that as we all understand, it's we talk about it so much. It's a small tool within the EVTM, the vascular world, the trauma world. But don't we have to now think of other solutions? The patient dies. We know that the patient died on day 1, 2, 3. So even if RTA brings the patient up to the ICU and they did a magnificent, really beautiful case, the patient might die in day 1, 2, or 3. Frank, Frank, you have experience in the South African side of it. These patients that died at some days, would you do things differently? Just some kind of tips.
Yeah, I think it's a couple of the patients were surprised at day 3 or 4 or 5 when they developed a lot of necrosis, a lot of bowel necrosis. There was one guy that developed quite a pancreatic necrosis on day 5, I think. Others developed like a colonic necrosis. And we know that there have been studies recently showing that if you do basically isolated colonic cooling, that's your outcome is going to be better because obviously you reduce the ischemic changes in the colon. But I think it's in a lot of cases it may have been just related to the fact that patients are still sick with lots of polytraumas and they're still on high dose of adrenaline days after the operation. In fact, it's the cases that died with necrotic bowel, actually they were for a very short period of time. Other cases that died after 2 or 3 weeks, I think it was totally unrelated to a requirement. It was part of the many injuries or total body crumble.
So I think that we just try to move on to the next presenter. Martin is going to share with us some of the unpleasant situation in England. So Martin, please.
Okay, I'll try to share my screen. I have not been hugely successful always. Let's see if I manage now.
It's there.
I'm getting there.
Yeah.
All right. So this is for me a little bit sad topic because it was fun the first 5 years. It was fun the first 10 years, but now it's becoming tedious, and I think it's a little bit shameful for the community of physicians that our endovascular opportunities still keep underutilized. And the way I see it, it's largely for dysfunctional logistics and politics. And because it's Sunday, and I'm sure you had a great time in Örebro yesterday, and everybody's a little bit tired, I have no doubt. I start with a quiz just to wake you up. And my question to you, this is obviously intraoperative image. It's a ruptured aneurysm with a mobile CR. It's an 80-year-old gentleman, and it's all very poor quality. It's the last image home. And my question to you guys is, what is this I'm showing you? You have 4 options. Is it Professor B's first AFR rupture case from 93? Is it a study of mobile versus fixed CRs? Is it the first AFR in space by NASA? Or is it the first AFR in 2018 in one of the richest and most expensive cities in the world? So what do you think?
Probably D.
Probably D. Shamefully D. And yes, it was in 2018 that the first rupture case was treated endovascular in this particular city, and it was with a mobile CR, just with a last image hold. And the most astonishing thing is that there is a neighboring center where over 80% of ruptured AFRs have been done endovascularly for many years. So after this, does anybody still believe that the variation of usage of AFR versus open surgical repair is for medical reasons? Does anybody believe that? We published our first experience of ruptured cases in 2001. So we are this year celebrating the 20th anniversary. That's a very long time, I think. So here comes my second quiz to you. What do you think the proportion of percutaneous AFR is in Europe's largest city, in the year of 2020, the way it has been communicated to me very recently by the lead in that city. Do you think it's 100%, 60%, 30%, or 0%?
I agree with you.
You're absolutely right. And again, at my institution in London, we are doing 95% percutaneous. It's fine. Does anybody now, after this, still believe that the variation of AMR versus open surgery repair is for medical reasons? Now, obviously, we are discussing all these studies endlessly, but it's not about that. There is an elephant in the room. The aim of treating the ruptured aortic aneurysm is to stop hemorrhage, and from the patient's perspective, there are two ways of doing it: the maximally invasive open surgical repair, or the much less invasive endovascular repair. And the outcome is obviously much different if you do it endovascularly. This is a gentleman who was worried about his hairstyle when I took the picture the next morning, because he knew I would be showing the picture worldwide. It's common sense. It's a no-brainer, to quote Frank Bees. I like quoting Frank, he's very wise. He also used to say that you don't need randomized controlled trials to test a parachute. And if you insist on randomized controlled trials, it's also that the mortality in the improved trial after open repair was 37% and 25% after AMR. And in Örebro, the team, together with the Zurich team, have shown that all ruptured cases can be treated endovascularly with a mortality in the range of 24%. And if you don't like trials, I've looked recently on population-based, the SweetVasc, the mortality in the elderly patients that we now predominantly treat, at least in the Western countries. And if you compare mortality after AMR versus open surgical repair, the difference is striking. When we look at how much we use endovascular techniques for rupture versus intact areas, there is also a striking difference. We do 88% AMRs in the intact aneurysms, but significantly less in the ruptured cases. And I don't think this is for medical reasons. Again, I think it is logistics not being in place outside of office hours. And then we have the variation between centers where, according to the national registries, the variation spans between 0% AMR up to 100% AMR. And the reasons are, as we say, multifactorial, and mainly it's the so-called logistics, lack of staff, people lacking the key to the angio suite. This is actually recent happening in London. Somebody is not signed off by somebody else who feels entitled to sign somebody off, and various types of politics, and perhaps also the volume of cases. This is again Swedish data. And if you look at the volumes of aneurysms per year, per center, and relate that to the percentage of endovascular repairs, the medium-sized centers to the right here, those over 40 aneurysms per year, do more than 40% of endovascular, and the large centers that do over 80 cases per year do over 60% AMR. So it shows clearly that this is not so much about medical beliefs, it's about practicalities, logistics, politics, that kind of things. It takes common sense that this is not advantageous to the patient, and there are, as I pointed out to you, centers neighboring to each other where completely opposing techniques are being used. And I think that if this came out to media, God forbid, if the patients knew, we would be seeing headlines like unnecessary operations carried out for ruptured aneurysms or even elective aneurysm repairs. And if people knew and it was their father lying on the table, we would probably have a new hashtag #MeToo movement, hashtag #MyFatherToo. And that's not something we want. So There is a huge variation in endo versus open. Utilization is unjustifiable that this persists after more than 20 years. I believe that endo remains massively underutilized. It began by sound skepticism. It then evolved to perhaps more conviction, but poor equipment, then lack of training, but now we stand behind largely with politics and turf wars. It's shameful. And the way I think it should be solved is by actually merging the various fighting specialties into a new modern global vascular specialty. I think if we manage to achieve that, we will avoid some of the stupid turf wars. It would for sure save money, and we would be able to offer the best treatment to the patient, not the treatment that our doctor on that particular night happens to be familiar with. Thank you for your attention, and it's wonderful to be with you, at least at some distance. I wish I was that. Thank you for arranging this.
Thank you, Martin. Great comments on how we are struggling sometimes. I remember that when we started to do the ruptured cases, it's as you say, it's a lot of logistics that needs to be solved. We started to talk with our ambulance service, and then we started to talk to our ER and the CT and everything. So it takes a lot of enthusiasm to carry on and build up this kind of infrastructure. And it takes a lot of efforts. That's why the resources are different in different parts of Sweden. So in some places you can offer 100% 24/7 ER to all the patients that come to the emergency department. In other places, you don't have the resources. So please, any comments on the Martin's? Yes.
Martin, thank you. Just one thing, and let me be radical now. Thomas Larsson is also here, and we are in our group. We will publish soon the data, and we are doing only, as you know, 100% EVAR on ruptures. I don't know if it's good or bad. We will, when it's published, then we can do judgment. But as you know, and you've been living in many years, it's possible. But the question is if we pay price for it, and the price of, and I know you don't like this question, but the price of education, the price of Artai will tell me, or another colleague will tell me, but can you operate openly? Is it okay to do open operation when you're not doing when you're doing it on endovascular tubes?
Yeah, but now you're raising the issue of performing procedures for the sake of training. And in my world, that is unethical. And you know, I happen to be married to a Norwegian woman. And in Norway, they had a funny artifact. I'm sure they have solved it by now. But when I was young, the trainees in general surgery would carry a bleeper because they needed to tick off that they had done a certain number of gastrectomies or gastric resections for gastric ulcers. And because we had the novel medicines, the number of such operations was so low. So in order to achieve the required number, they had to travel urgently all across the country to get enough patients to operate. I don't think gastric ulcers patients should be operated on open only for the sake of training of surgeons. And for the same reason, I don't think that vascular surgeons should be doing open surgery for the sake of training. I do agree that we still need open surgery, but the open surgery that remains is for those patients that we cannot solve endovascularly. That means that they are the most difficult cases, and they are fewer and fewer, more and more difficult. And for these reasons, that is the type of surgery that needs to be aggressively centralized to lead to a few leading centers and to a handful of colleagues who then hopefully will have the opportunity to gain some personal experience of that type of procedures.
Great comment. I totally agree with you. So let's go on with the next presenter. Victor Riva is going to talk about a very interesting topic, a different way of thinking. So please, Victor.
Can I go from here?
Yes.
Thank you very much. And Actually, my talk is demonstrating that the circle of EVTM is spreading, and this is like an extension, one of the ways where EVTM can go. Even compared to the previous Örebro EVTM Symposium, where we discussed more issues about access and the board, now many different topics arise, and this is probably one of the topics. Actually, my co-author here, Alexander Babish, who developed a technique of this actually type of perfusion of the brain compared to, so everybody knows that there is perfusion of the limb for melanomas and different other regional perfusions, but actually no one concentrated on cancers in the brain and neck, how we can use perfusion techniques to treat them. And so for their idea of the study, you can see here that no effective treatment options for many glioblastomas in the brain and different other malignancies in the region. And mortality is very high, and so we have no enough data for adequate treatment of these malignancies. So there are a few people we should cite here, and we are standing on the giant shoulders, and Sergei Brikhanenko, I will demonstrate his movie from probably 100 years ago done. And when I see such studies and trying to analyze deeply what had been done before, and I see that almost everything already done. You just go in spiral and reinvent some things that were done before by our previous.
Animals again can also live in the isolated condition. Here is a plan of the experiment.
It's the experience with isolated head of animals done.
The artificial blood circulation ensures the mechanism necessary for the life of the head. The isolated head lives on for hours and reacts to external stimuli.
Yeah, I just showed them this movie to demonstrate that the fantastic stuff was done before by some scientists and surgeons. And our study was planned to reinvent this and to use this technique or develop endovascular technique to treat malignancies in the head and neck. So we tried, for the first time, we tried this experiment in sheep, just to understand whether it's feasible or not. And the next step is, so we elevated to the next stage. We have a big institute of primatology working on primates in the south of our country. And we used this technique in Papilla hamadryas, baboons, like monkeys. And it was not a randomized trial, but we used 3 animals for open technique and 3 animals for endovascular technique, just to compare whether it's feasible to do endovascular procedures for isolated perfusion of the brain. We used one, so they were normal, healthy animals, but we used carboplatin as a drug of choice in treating some malignancies. And the second reason why we used it, because you can check the level of platinum in the blood, so to compare the amount of platinum in the circuit and in the systemic circulation to check whether adequate perfusion is performed or not. So the techniques are presented here. Open technique is a cannulation of the main vessels, and the endovascular is quite the same, but using kind of large bore catheters, balloon catheters, kind of SAD catheters or something like that, with the balloon occlusion and perfusion of the distal part. So first we analyzed the anatomy of monkeys just to check whether it fits to human anatomy, and it was quite the same. In some aspects, we had a little bit different when there was a brachiocephalic trunk and no left carotid artery, and so there were only two vessels, brachiocephalic trunk and left subclavian artery. The second stage was the perfusion itself, and we performed a circuit just to isolate head, and then we inject 4 times higher than systemic highest possible dose of carboplatin. So it was a quite big dose with a huge systemic toxic effect, and try to evaluate whether the animal can tolerate this type of perfusion. As the third stage was completion of procedure, removal of the cannulas, extubation of the animals, and then we check them for 30 days. This is how it looked like during open procedure. The first picture is an exposure of via median stenotomy. We exposed all the vessels and checked using some magnetic cerebral oximetry whether we are doing the right thing or something is happening with the brain. And then the vascular, it looks like many catheters are everywhere in the femoral region and axillary region. Here you can see that we perfused, at that time, we perfused via the axillary artery. We had no big SAP catheters, so we used just reborn catheters and perfused the aortic arch via the axillary one. Here you can see how it looked like during angiography, normal anatomy, and the balloons positions, like you can see here, one balloon in the IVC and balloon in the brachiocephalic trunk and left subclavian artery to isolate it. And by the way, we previously embolized the main potential sources of leakage, like internal mammary artery and thyroid cervical trunk. And you can see the first picture is contrast injected into the circuit, and another one injected into the systemic circulation to confirm that there is no leakage. This is a picture after the procedure, and we were looking for a platinum layer, and the concentration was much different in the circuit, higher in the circuit, but there is a leakage. Anyway, we couldn't completely isolate their head, but the concentration, as you can see, is quite big. So we found that endovascular techniques is the same, that there were no difference in concentration level between endovascular and open procedures. So we found that endovascular technique might be possible for use in this procedure. The main question now whether it's effective in treatment of neck and brain malignancies in human patients. So further studies are warranted to prove this. Thank you very much.
That's a very innovative way of thinking. Any comments on the floor?
Is it Tal speaking, or is it Altay?
It is Altay.
Hi, Altay. May I just mention that we did some trials that may be perhaps closer at hand to most people in the audience. We struggled with those completely trashed lower limbs, particularly patients with popliteal aneurysms who completely trash their outflow, even the smallest vessels in the feet. And what we did was we connected the lower limb to a heart-lung machine and put stasis on the side, and we perfused the lower limb with oxygenated blood with a high concentration of RTPA and heparin, and tried to see if we in this manner could open up the smallest blood vessels in the lower leg.
Thank you. Victor, any more comments on how you are going to proceed with the project?
Actually, we proceeded with the project, and now we have 2 patients already perfused with this technique in reality. So we received ethical approval for moving and pushing this technique forward from our chief oncologist and institutional protocol. There are a few centers in Russia pushing this technique forward in Moscow and some other cities, Krasnodar, St. Petersburg. So it is now being evaluated in clinical. So it is that we just need to find the right patient for this procedure. Because it's not first-line therapy, of course, it's a last resort option.
We'll be glad to hear more from that. Yeah, so let's move on to the next topic. Hong Kong, I don't know. Please come and you can prepare. Simone, is it you online? Okay. So Hong Kong is going to tell us something about how the Reboa education has proceeded in Thailand. Please.
Okay, good morning everyone. I'm Dr. Wansu from Thailand. Today we present about EVTM training in my country. First of all, I would like to thank you for EVTM Society to be here. And so my past training, of course, with the EVTM, the experience with the EVTM workshop and best card in Baltimore. So to set up about the training program, we see how different what we have and look into the results, looking about our trauma system and about the training background who will perform for the reward or EVTM this year. And then, so the Thailand, as we have the world known for the famous surgery and food, however, sadly, we also were known for the traffic injury days. And usually this happens in the major city in Thailand, and our system is like a multi-tier hospital. It's mean like we have university hospital, provincial hospital, and like a private hospital. So we have trauma center, but sometimes patients do not directly transfer to the trauma center. If happens in the city center, we send to the closest hospital. If lucky, like the Bangkok capital city, we have the major hospital that can do resuscitation and some like a EVTM. But in some COVID, the patient will transfer to the smaller hospital and then transfer to the big hospital. This means that every hospital has to be ready to do the trauma resuscitation by themselves. And about the training, so if imagine about the patient come to our trauma bay in Thailand, we have the many staff and also the many members to take care of. We don't have a necessity to play with us in trauma bay because we very busy already during their on call. This means our resuscitation team have to do that. And also if to do the reward, it's gonna be like another team that to do the reward and assistant, and also the surgical team to do the asset and some essential like a shade tube. Another side, TTL can be like an ER or trauma staff. This can happen in the university hospital that have many members, but in some smaller hospital they have to train and prepare for their team. Sometimes nurses have to help them. So this is my center. We have the trauma bed in trauma bay, like we can accept the full-time exam like unstable. We separate from the ER, and OR is just beside, it's just like within a second. So this can happen in the university hospital. So for the training design, to answer about the trauma system and facility, this means that everyone have to be ready and trained for the resuscitation. And for the training background who perform at the beginning, we will start with the surgeon first because they get to with the endovascular skill and to know how to detect the complication. For the IR, they're not in-house, and ER physician, they're very busy with the MI and stroke already, so the answer is going to be the surgeon. And so our setting is training is about the procedure and the concept. And of course, we have for the on-site training. That means that everyone can record and practice. And also we teach the nurse to do some invasive monitor like arterial blood pressure to see the response of the resuscitation. And we set up with the multi-team expert for the many protocol to do the EVTM for the trauma patient. So to officially begin, we start with the civilian team help us 4 years ago. The Thai and team will sit to see about the training program and the trauma system. And also we have the official workshop. This is like an emergency workshop because we just have like a 1 week, 1 month to prepare this. And we have the introduction, the workshop at that time. It's like a nickname, it's an Thai workshop because he give a lot of presentation and teach us. And we also have like a demonstration hand-on. At that time, we plan to teach the last year resident, but you can see like many members to join because our team includes the nurse and junior staff and junior trainee. And then to answer about the adult learning and skill retention at the first workshop, we can reach until the discussion part is 50%. We plan to have more like to set up like more realism about to have the chance to practice for the reward and EVTM. So we have the perfume fiber in our center. So and this is like the very big workshop. One is include all the resuscitation procedure for the trauma, start with the airway, chest, and include the vascular aperture and also the reward. But because of the many procedures to be done during the workshop, it's limited time. Some table can do the reward, some table is just only like a demonstration to fulfill the like this limitation of time and practice to inform the carnival workshop. We set up for the on-site training for the trainee that they can ask many times. This is like a Sweden set up for the origin model and we prepare the devices. Residents can ask like during the on-call if they want to practice for the vascular access and reward. They don't have to attend for the official program. They just ask. And also our team training like nurse can ask for like a recall or practice to help the procedure too. And then the vascular team, they develop like local way for the vascular access training with the managing can do the ultrasound and practice for the percutaneous and with like a red fluid like a valve. And then the next step to design the workshop and training, we plan to reach all for the retention skill until the practicing and also the teach each other. So our latest workshop is 2 years ago we paused because of the COVID. And then so the adult learning skill retention and we have tools already. And we will focus with the trainee is going to be teacher in the future because they can teach their team in hospital and so enjoy our team during teaching. And so we limited number to participate first because they wanted to give them to spend time to discussion and practice one by one and fully hand-on. So our design workshop is started with the introduction about the reward and the vascular concept with the focus with the resuscitation together. And about the reward, we have the basic and so coping with the complication and including the possible look at the medical that they have to take care of the critical care by themselves for some center. And for the hands-on, we have the like basic vascular access with the aortic model to try to practice for the partial and reward to see the response with the map target. And all like a full step by step with the reward in the perfuse fiber. So the benefit is very important for the perfuse is a high correction and during the resistance of the reward inflation, and it's a way for the to practice for vascular security for the general surgeon. So actually it's come from nature residency and also from the quantity hospital to attend. And to sum up for our EVTM training strategy is going to be the comprehensive program, not only reward vascular, it's going to include with the resuscitation concept. And it's going to be the EVTM concept is implemented more in the future and with the more team training and from the collaborative formative hospital. And of course, we plan to have for more assessment and quality improvement program. So the challenge is about our workload and also the related disorder we have. So we'll see what we can bring back from the EVTM Society Symposium in the future. Thank you so much.
It's amazing to see that you started like 4 years ago, and in these 4 years, all these things have happened. It's really amazing to see.
Yeah, it's actually it's 4 years and then until 2019 and then pause because of the COVID.
Yeah, sure. So any comments on you great experience to start with this kind of program in hospital? Any comments on the tour?
I've got a question.
Yes.
Phenomenal experience. Can you tell us what, obviously, Thailand is also a country with a similar GDP, and bigger GDP as South Africa, particularly your health expenditure per capita. But how do you find the access to the catheters in terms of costs? Do you find any cheaper local solutions for required catheters? If you try, I can see you're also doing open procedures. They're also looking at using the hybrid method as much as possible, or just sticking to the use of revoirs for every case.
So about the EVTM apply to our the trauma case. So my center is University Hospital. We have the trauma resuscitation room and OR just beside. So we have the all staff is done like a hybrid OR. So we do like a damage control for with the rigor, and then for hybrid theater is going to be the next building. So during that time, we will call them, and actually we call Annette to be ready to be there, because during the resuscitation, anesthesiologists don't need in our room, because we can do it ourselves. And then for the cost and the two staff, we have already, and for the what we working for now, we try to do like a reimbursement, but we have to collect the data to ask for government to pay for that.
Okay, thank you so much. So thank you so much for this. Let's move on. I invite Thomas Larsson to tell us something about the future.
Thank you, Artai. Thank you, Artai. I'm going to talk about first aid platform, which is based on central and digital technologies to integrate parameters and make it possible to, in real time, read these data. I have one disclosure that might be in conflict with this talk, and it's my position in the vital science innovation. However, I would say I have not the business hat on my head today. I'm more have the doctor's hat on that view. So if you look back for what has happened during the last 2 decades, and looking on the, so to say, value chain from the scene of the accident to actual treatment of the patient at hospital, not much has happened at the scene. Well, we have got cell phones, and we have GPS positions, so it's easy to communicate and localize where trauma is. In the ambulance, sensors have made their entrance now, and more data can be collected and transferred to the hospital records. And that is a great step forward. And also, the ambulance can bring very skilled, a very, very good skill set to the scene. For example, by ECMO, like what the team in London and Paris do. That is very exciting. When we come to the emergency room, we have new protocols, new guidelines, and especially this, what with having early arterial access and the use of REBOA has changed how we treat these patients today. And we have also better equipment. We have suits, hybrid suits. We have a combination of MR and CT. And when we go to the real end station, the operating room or the cath lab, we have almost everything in that tech. It's incredible what we have got through during the last 20 years, and imaging systems. We have talked about that before. And we can always invent more. We are like oil drillers. If the oil, we empty one pocket, we drill deeper, and that's what we have done. I mean, we can, Elon Musk can bring people up and take down the rockets and reuse them again. That was impossible in the future before. And this is a Google project by the mother company Alphabet. that is an ocular lens that measures glucose in the tears. This project is postponed, but it shows what is around the corner, so to say. And even more, I'm thinking about Victor's presentation of the brain. This is a very amazing, but also in a way a frightening project. It's an Elon Musk project, also the Nebula, where you really start to interact with the brain. And the good thing is that there is a possibility that this could be of value for Alzheimer's patients and for paraplegia. But on the other hand, what happens if you start to intervene in the brain of humans? You never know where that will go. So the new oil is maybe not by drilling deeper, it's to find a way of good communication between the drill holes. And that's where I have focused now with this first aid platform. And it's basically a sensor where you place in the ear canal, like an AirPod, and wireless communication of vital parameters goes to the first aid platform unit and the display. And also data is transferred over the mobile telephone netting in real time and can be read by end users like David in this case. So this way of communicating information, I will say, create values for users. People at the scene of the accident can get support. There is a high stress level, and I think this is a very good thing. Ambulance personnel can be prepared, trauma team at hospital can start and plan, and most of all, this is of benefit for the patient when you have a better flow of treatment in trauma, and also for the society. But even though this makes sense, it will not be a walk in the park. We have a challenge, and this is the hierarchy system, and it's very hard to come with new innovation in these structures. And if I look back on my own professional career, I would say I've also been an old driller, but we need to find real ways to communication. I have this quote from Terry Winograd. He's an icon in the computer industry, and the common sense understanding of processes for conducting business. That's the key, and some remarks that it's not just what's spoken, it's also what is unspoken. And this active listening, rather than trying to convene someone with information, that triggers interpretation. So we have a very challenged future, but an exciting. Thank you for listening to me.
Thank you, Thomas. I think you're touching the point that we've heard a lot of discussions about taking the like pre-hospital removal to start to take care of patients at the scene. A lot of things are not clear about the strategies, but I think one of the things that is going to make us make the correct decision in the right patient who is going to have benefit of actually getting care at the scene is to have this kind of tools, to have the information, because then the decision-making process will be much easier. Any more comments? Thank you so much, Thomas. Thank you.
Thank you.
So let's move on with Victor again. Welcome back. And you are going to touch a very good topic. Subclavian injuries could be quite horrible to attack. It could be a nightmare and challenge. So please.
Thank you, Artai. And I'm going to talk about a surrogate of EVTM that we have. So in Russia, probably in St. Petersburg, they're not very good at EVTM. 100% of EVARs are done for ruptured aneurysms. And we're trying to find some alternate options to deal with the very difficult, tough scenarios. And everyone understands that supplemental injury is high lethal and that can lead to high morbidity. And the options to treat them are, so there are no many options. So we have the classical traditional one with the open, quite big incisions, aggressive surgery with median stenotomy, hook thoracotomy extended to the neck, or according to the certain injury. We had a case just a few years ago with such an injury, subclavian artery. However, we had EVTM options at that time, but trauma team leader didn't find the solution to make it in the right way. There was open exposure with the extended from supraclavicular access to median stenotomy, and the patient was deteriorating because of other injuries, and it turned out to be a better way to put a shunt, and then a shunt thrombosed, and then the patient lost the arm because of all these aggressive procedures, and the result was devastating. Another option is from the books from Top Knife, very nice book, which is there on our desktop actually, to occlude the origin of the left subclavian artery. We have mini thoracotomy in the third or second intercostal space to clamp it semi-blind, and then to proceed with the go straight forward into the hematoma after proximal control. Different ways in limited, resource-limited environments. If we don't have covered stents or something else, we can put the balloon in. For proximal control, we are using fluoroscopy and then go into the hematoma to fix the problem. It was presented by different in different papers. Thomas Calais was pioneer, probably occlusion of the subclavian artery, left subclavian artery for temporary hemorrhage control. So the aim of our study is to find maybe less expensive ways to control the left subclavian artery for axillary and subclavian artery injuries. And hypothesis for the thoracoscopy can be used as a surrogate for EVTM options or open aggressive techniques to control left subclavian artery. Is that in our country we are extensively using laparoscopy and thoracoscopy techniques even for emergency procedures and in trauma. One of the biggest review in Journal of Trauma demonstrated that most of the cases were done in Russia during the last 1 or 2 decades. But we used cadavers to demonstrate the efficacy of the procedure, the data presented here, and consequently on one cadaver we found endovascular, thoracoscopic, and open control of left and right subclavian artery. So we found for the time and efficacy of the procedure, and the whole idea and methods are presented here. How we did endovascular was done via when the vascular sheaths were inserted. The time for vascular access was not recorded because so it is much more difficult with cadavers to puncture the femoral artery blindly. We did it via cut down, and thoracoscopic procedure started from ports when ports were placed into the third and fourth intercostal spaces as presented here. And median stenotomy was done for control of both left and right subclavian artery. This is just a representative video of how we did thoracoscopic control of the left subclavian artery on cadavers when we placed the cords, and their camera was inserted. We used 2 manipulators and graspers to mobilize the left subclavian artery and clamp it with the bulldog, or even we can clamp it with a grasper for temporary hemorrhage control to avoid intimal injury, intimal tear, and median tear. Then we can proceed for subclavian artery exposure and fixing. So the main data presented here, we succeeded in almost all cases, and there were some failures as presented here, and 2 times we had failure because of iliac artery occlusion, so endovascular procedures were failed. And this should be kept in mind in real scenarios when elderly people has some injuries to the subclavian artery, some failures because of malignancies and severe adhesions in the pleural cavity couldn't just expose their right subclavian artery. According to type of operation, left and right, we found that endovascular procedure was much faster, and it took about 1 minute and a half to occlude the subclavian artery, and the left subclavian artery was easily controlled. And thoracoscopy was the second place in a row. Open procedure took much more time to control the left subclavian artery. And compared left to right, you can see here there was a statistically significant difference between the left and right in endovascular, and no statistically significant difference in exposure of left to right using thoracoscopic and stenotomy techniques. So we found that it's possible to use thoracoscopy mostly for left subclavian artery, because at the right you should mobilize brachiocephalic vein and then go deeper into the fat to expose the right subclavian artery. Probably it can be used as a surrogate for hemorrhage control in cases of auxiliary subclavian artery. Thank you very much. Open for questions.
So, what do you see kind of potential if you want to use it in your patient? I mean, if there's an injury around this, so clearly the artery is only hematoma, and what do you think? Is it going to be easy to access the subclavian artery?
I think in the case of so first or second segment of subclavian artery injuries, that was probably impossible to claim because of hematoma in this region. We need to control even more proximal. That means that, but in this case, it may be difficult even to control using endovascular methods. Probably in so we had a case with the injury of the origin of the left subclavian artery. You cannot control by any other means except stenotomy. But for axillary artery and third portion of subclavian artery, probably there is a potential for using this technique in practice. It's fast, and so for limited resource environments, I would say that can be used as an option.
Yeah, we use it in South Africa in real practice, quite a few, the thoracoscopic approach. The proposal that you use is so you can completely only make one line of process for the left side. And if you don't have it, if you know it, you can also use the heating tube into the right bronchus and make that work. So then you basically isolate it a little bit away from the whole of the thing, and then you can stand, put a vessel loop around and leave a bulldog on the vessel loop, or even a little clamp on the vessel loop to keep it in place. So it's not very difficult.
Yeah, it's a great technique, Vicar. I've never done that. I have done a few open books, but if you did have the bulldog on there, then you could simply take out the medial third of the clavicle, and it'll take you right down to the subclavian. So you would avoid a big thoracotomy. Once you have proximal control, that ought to be easy to do.
Great point.
May I ask, how to gain endovascular control for proximal subclavian lesion?
I think,
you mean why don't we get control endovascularly?
Yes.
That's because of sometimes in many places in Russia, we have no availability for full and proximal service. So that's.
But doesn't this reflect what I tried to touch on? That I think that the thoracoscopic technique you showed is wonderful, and I would like to congratulate you. It's so skilled and it's great. But I think that in most people's hands, it is actually more difficult and more resource demanding than the endovascular approach. So it's all about logistics and equipment to kind of redirect our focus to the endovascular, then I believe we'll be able to solve more problems more easily.
And I think that endovascular means it's just a matter of control of the bleeding, so you don't need to have fancy stent grafts, stuff like that. So just with a balloon inside the brachial artery or the axial artery control.
So in South Africa, it's a lot easier to get your thoracoscope, take the patient to theatre and go around the subclavian and to get an interventional radiologist to come out at 3 o'clock in the morning. So it's from a practical point of view, I think it's it sounds a bit scary because when you run it onto the auto and start using the scissors. But I mean it's a lot easier. You don't need to call anybody else on the
I think the other potential application would be when there is a transection of the second portion of the subclavian and you're trying to bridge it, and it's a risky endovascular, then you can go into proximal control in order to allow you to do your endovascular stent. I heard of a case, I was visiting a hospital and a motorcycle victim had mid subclavian left, and they went in, the interventionist went in and put a wire into his chest and he bled to death because they had no control. So I think for high risk injuries, that may be again a hybrid way to do it, is to get your proximal control with your thoracoscope and then do your endovascular.
Great comment. Thank you very much, Victor. We move on. Unfortunately, Greg was not able to stay because of the flight situation. So we go on with Marisa.
Because of the flight situation, we should go.
Online.
Thank you very much. Thank you. So we should be in contact about Russia. That'd be great.
Do we have contact with Marisa?
Thanks for coming.
Hello?
Hello. Please. The microphone is yours. Hi. Nice to see you.
Can I share my screen? Okay, you see my slides?
Yes, please.
Okay. Good afternoon, everyone. Thank you for the invitation. My name is Maisam Shihab. I'm a vascular surgeon. Okay, I have no disclosures. I'm going to present our experience with the subgroup of patients with hemodynamic instability from different causes, whom underwent exploratory laparotomy when early arterial access was not obtained. In our institution, we as vascular surgeons promote early arterial access and Reboa use. However, in our reality, vascular surgeons are not always involved in the early treatment of the patients. The etiologies include 2 postpartum hemorrhage, 2 trauma cases, 2 GI bleeding, 1 upper GI bleeding after EVAR in the past. Another was a post-abdominal surgery bleeding 1 week after the post-surgery. In all cases, Reboa was inserted through a femoral cut-down positioned in zone 1 and zone 3. A partial inflation after initial stabilization was applied in correlation to blood pressure in all cases. In 5 out of 6, Reboa was inserted without fluoroscopy. No major Reboa-related complications occurred. However, there was 1 access-related complication with local common femoral dissection and thrombosis that was repaired immediately after sheath removal. All patients survived perioperatively with 3 to 6 months follow-up without mortality. I'll present 2 of these cases. The first one is of a 28-year-old female who had an emergency section, and a few hours later she suffered from hemorrhagic shock. They took her to explorative laparotomy, and bleeding from the uterus suture line was observed. They fixed it, and she was hemodynamically stable, and they closed the abdomen. However, within an hour, she had a hemodynamic deterioration, and she was reopened. They found an expanding zone 3 retroperitoneal hematoma, and they called us to assist. We inserted Reboa and inflated in zone 3, and the patient stabilized. So in this time, we transferred her to the ICU suite with full balloon inflation. And after we got there, we began to deflate the balloon partially in accordance to her blood pressure. We performed embolization with onyx, as you can see in the pictures. And the patient and her baby were discharged home on midday. The second case is of a 24-year-old male with a gunshot wounds to both abdomen and lower extremity. He was unstable. They performed resuscitation and took him to the operating room for emergency laparotomy. They found expanded retroperitoneal glaucoma in zone 1. They called us to assist. We inserted Reboa in zone 1, blood pressure stabilized, we performed exploration, and large laceration with the IVC was found. We performed primary repair. The patient was discharged 3 weeks later. To conclude, Reboa is a resuscitative tool to be considered, even in the open abdomen. Reboa with full and partial inflation reduces aortic vein morbidity. It allows for rapid hemodynamic stabilization and definitive multi-team surgical repair of major injuries. Thank you.
Thank you, Marisol. Excellent. I just want to hear your thoughts about when you started to use the Reboa for actually first case. Had you prepared to do that in the time, or you just happened to use it?
When they called me to come and told me it's an open abdomen hemorrhagic shock, first thing I had in mind is to consider Reboa, and on the way I called them to prepare the kit in case I will need it. So of course, Reboa is one more tool in our toolbox to consider in the right cases, and I thought that they were the right cases to perform, although the abdomen was already open.
So when you do something for the first time, a lot of people can have ideas, skepticism. Did you meet enthusiasm or skepticism in your side?
Skepticism at first, but when they saw the results, and I think it was mixed up between those who were in the room and those who were just heard about the case afterward. Those who were in the room were very enthusiastic about it. And but those who weren't in the room, you have to explain to them why you choose Reboa and what exactly happened there. And the results talk for themselves. All 6 patients went home with no major complications.
Perfect. Any more comments on the floor or?
Thank you for your presentation. I would like just to ask you if you would like vascular surgeon, if you would like to replace Reboa other instrument, would you have done it that way, like vascular surgeon?
Yeah, of course. In other cases, I performed it percutaneously. If that's what you mean, how to insert Reboa?
I mean, if you would like to treat a patient in another method and Reboa, do you think that it would get a good result as you get in Reboa?
You mean if I put a superciliary claim, for example?
Yes.
Yeah. Well, yeah. It's as I said, Reboa is another tool in the toolbox, but in some cases, a superciliary claim is also a good option. But for example, the thing of partial inflation in Reboa, I think, is very important because in all cases, I spoke to the anesthesiologist and performed partial inflation and in accordance with blood pressure. So it was not all the time full claim. I think it's a big benefit that superciliary cross claim will give me. And I think this is one of the reasons that these patients did not suffer from cross-claim complications and morbidities.
And you said you did both with cut-down technique, not with puncture?
Yeah, I was already in the operating room and
cut-down technique is not very time-consuming to a vascular surgeon. And there was not an ultrasound available, so I decided to do that cut-down technique. Of course, in other cases that we perform in the emergency room, we use a percutaneous technique, with or without ultrasound guide.
Great, so thank you.
Let's move on. We have a couple of comments. We start with Frank. Frank, please. Start.
Yeah, I agree. The first case in South Africa by one of my colleagues was also done intraoperatively. And
I can't hear you.
yeah, sorry. The first case done in South Africa by one of my colleagues was also done intraoperatively. And basically, it was an injury next to the aorta, quite high up. It would have been very difficult to actually dissect in the hematoma near the aorta. So even if it was the abdomen was open, it's sort of the right thing to require. So I think we did it. But obviously, it was also met with skepticism. Lots of, we were in the abdomen, wanted to use Foley's cap close to one pound, and it was going to cost you somebody's salary, 3 monthly salary. So it's a matter of God decide. Certainly made a lot of sense.
Let's go on with Boris.
Yeah, it's an issue. It's very controversial. Some people will say what to use before in the open abdomen. Yeah. And me personally, I support such approach very well. Some people may say that superciliac clamping is really simple. I do trauma for more than 20 years, and sometimes it's very difficult procedure. Image to yourself, very patient or very hypersthenic patient. I don't tell about hematoma, yeah? In virtual area, in some patients, it's very difficult, hard, and time-consuming procedure. So in selected cases, it's much easier to use before in open abdomen, and I support it very much.
Thank you. We go on with the last remark from Martin, please.
It's not a remark, it's just a question. Why did you use onyx?
Okay. First, I didn't use that. It was the radiologist. But when I asked him why onyx, he told me that he's familiar with it. And one of the lectures that was in the EVTM Symposium was about that issue, and that you should use what you're familiar with. And I think it answers, it's relevant to what he told me when he decided to use onyx.
Okay, thank you very much. Excellent.
Yeah.
Can I get a comment in, please?
Very fast one, please.
I think, first of all, I would like to explain that part of this approach was used because of the lack of training of a lot of our general surgeons in endovascular technique. Although wherever we can be involved, we try the percutaneous access, but unfortunately, the surgeons have learned in a kind of backwards way that when it's their turn to ask for the help of the vascular surgeon to help them in getting some aortic clamp and damage control, it has proven to them that Reboa has a place in GI bleeding and then the gynecologists in their postpartum cases. This way, unfortunately, we have thought that there is a place for early access and to make change some of our approaches to all of these cases and get the early access and to try to convince the general surgeons who feel very inadequate in their endovascular techniques that they need the best course, or they need basic endovascular skills in their training, which is something I wanted to comment on our previous session, which I couldn't get my hand up fast enough, but I believe that there must be, as Martin said, and as David, I feel that the training today, there has to be a major change in the way that we train our general surgeons, general vascular, endovascular, trauma. There has to be a paradigm that can give our new doctors and young doctors the tools they need to deal with EVTM and trauma management.
Thank you very much. Thank you. We have a lot of challenges to solve in the future, but let's move on with Maya. Please, Maya, welcome. And you're going to talk about one of the most important things, the timing, please.
Good morning, and I thank the organizers again for the opportunity to present. This study aimed to investigate the effect of time to surgery on clinical outcomes in unstable isolated abdominal trauma patients. I have no disclosures. Abdominal trauma is a common injury associated with significant morbidity and mortality. There's a wide consensus that hemodynamically unstable abdominal trauma patients should be treated with emergent laparotomy. Time from admission to operative treatment is considered crucial for patient survival. However, only a small number of clinical studies have actually investigated whether shortening the time from admission to definitive treatment does indeed reduce mortality. A North American study published in 2002 reported that in unstable abdominal trauma patients spending less than 9 minutes in the emergency department, the probability of death increased with time to laparotomy. However, a Japanese study published in 2020 found no association between shorter time to laparotomy and decreased mortality. In addition to these mixed results, when time of surgery is discussed, there's no clear definition of what is immediate laparotomy. In order to answer these questions, we planned a current study which aimed to assess the association between time to laparotomy and mortality in hemodynamically unstable isolated abdominal trauma patients. This was a retrospective study based on data collected from the Israeli National Trauma Registry database. This is a registry that collects data about trauma patients from 19 different medical centers across Israel, 6 of which are level 1 trauma centers, and 13 are level 2 trauma centers. We included all isolated abdominal trauma patients, blunt or penetrating, with a systolic blood pressure lower than 90 on admission, who were admitted between 2000 and 2018. Patients with other injuries and an abbreviated injury scale higher than 2 were excluded from the study. Data was analyzed separately for blunt and penetrating injury. All patients were divided into 2 subgroups. We used 2 different terms: immediate laparotomy, referring to without loss of time, as opposed to expedient laparotomy, a term coined by Dr. Bosch while working on this study, meaning as soon as possible while allowing adequate preparation. The immediate laparotomy group included patients undergoing laparotomy within 60 minutes, and the expedient laparotomy group included patients who underwent laparotomy 60 to 120 minutes after admission to the hospital. We compared the clinical outcomes in these 2 groups, looking at length of stay in the ICU, total length of hospital stay, and mortality. In addition, we stratified clinical outcomes based on ISS and GSD. We identified 127 patients with penetrating injury, including 109 patients in the immediate group and 18 patients in the expedient group. There were no differences in age, gender, GSC, or ISS. Length of hospital stay was longer in the expedient laparotomy group. After certification in patients with ISS of 16 or higher, length of stay in the ICU was significantly longer in the expedient laparotomy group, but no other differences were found. We identified 69 patients with blunt injury, including 40 patients in the immediate group and 29 patients in the expedient laparotomy group. No differences in age, gender, or ISS were found. However, GSC lower than 15 was significantly more common in the expedient laparotomy group. Interestingly, we found mortality rates to be higher in the immediate laparotomy group, and the more patients in the expedient group had a lower GSC. After certification in patients with ISS of 16 or higher, mortality rates remained higher in the immediate laparotomy group. Similarly, in patients with a GSC lower than 15, mortality rates also remained higher in the immediate group. In summary, mortality rates were higher in the immediate versus the expedient laparotomy group in both penetrating and blunt trauma, as shown here in light blue. The difference reached statistical significance in blunt trauma patients overall, as well as for more severely injured patients with a high ISS and a low GSC. However, this study has several limitations. This was a retrospective study with a rather small sample size. Patients who were operated immediately may have been more severely injured in a manner that is not represented by data recorded in the registry, such as patients' response to resuscitation. These patients may have been true non-responders. In addition, ISS doesn't always truly reflect injury severity, especially penetrating injury. Of note, Israel is a small country and transport time to the hospital is relatively short. This study only investigated the effect of time from admission to the hospital to surgery without taking into account the transport time to the hospital, which may vary significantly in different countries. In conclusion, as opposed to what we might have expected, we found increased mortality in the immediate group. In other words, we still don't know what is more important, time to the OR or time to resuscitation en route to the OR. We would like to suggest possible explanations for our findings. We believe expedient laparotomy may allow for better preoperative resuscitation and better preoperative preparation, including availability of blood products, preoperative imaging, involvement of senior trauma vascular anesthesia team, and possible utilization of hybrid treatment measures. Thank you very much for your attention.
Excellent presentation and very nice data. So we've been talking about a lot of physiology. Do you think that we by doing laparotomy a bit later, the patients perform better regards to the physiology parameters?
I think our results are surprising, and I think one of the things is really the resuscitation. We don't have data in the registry regarding the patient's response to resuscitation, but I think getting a patient to the OR when the patient is resuscitated properly may allow for better results.
Any comments?
Yeah, first of all, it's an outstanding talk and very nice, but I would like to state a few things. First, after the proper study that checked the superiority of 1, 2, and 1 comparing to 1, 1, 1, there were extrapolation and several studies that were taken out of this study, and one of them showed that the time of coolers reaching the trauma bay and the time at the most, the more the time that the blood was starting to gave a better survival of the patient. And one of the things I think that didn't take into consideration in this case, it's the damage control resuscitation that the patient received or not received, and it showed that study and in other studies direct correlation between survival. Another thing, as you mentioned, that there is oftentimes selection bias, and the patients that are less stable are going earlier to the operation theater, and in that case, they have worse chances to survive. Another thing, the abbreviated injury score, sometimes because of the injuries are spread on more systems, is higher, but not necessarily correlates with the prognosis of the patient. If you have one system that is severely damaged, you may have a lower severity score, but also lower chances of surviving. But otherwise, really nice. Thank you.
Thank you. One thing I would be really interested in is that if you could find a pattern that the more experienced surgeons would allow resuscitate a bit more before taking the patient to the operating theater, would be really wonderful. With that, I give to Boris. Boris, you have some comments.
Yeah. Well, first of all, I completely agree that this study is much more questions than provide answers. But however, please go with my logic. For example, in every given country, gunshot guy patient goes to trauma bay. Why he doesn't go to operating theater immediately? Because we learn that we spend much more time with logistics in OR. You have no information, you have no sticks, you have no anything. The nurse staff in the trauma bay is much more experienced with internal surveys than nurses in operating room. And sometimes you bring patients to OR unstable with no resuscitation, you're providing intubation. What intubation does? Vasodilatation and immediately drop in the blood pressure when you are unprepared completely. So just wishful thinking. Maybe adequate resuscitation is much more better for our patient in 10-15 minutes than rushing to OR. I don't know exactly the answer, but just raise the question.
Thank you so much. Yes.
Just a comment to answer to your question, and because I support what Boris told us and what our colleague. The point is that it's not a matter of the surgeon allows for resuscitation or not. The point is that the teamwork. So you have to trust in your anesthesiologist. He or she is in charge for resuscitate the patient together with the surgeon and decide how many rooms there is for improve the condition. In the meanwhile, you are rushing to the operating room. Because if not, as Boris told us, when you start, the patient will get arrested because he crashed with the pressure and things will precipitate immediately after the intubation. This is the point. Not the surgeon, but the group is in charge to decide when and where to do the resuscitation.
Very good comment. I think that the fact of resuscitation doesn't stop when you are moving to a OR. It can continue on the way to the OR if the team is working together, then there's no room to stop the resuscitation. So this is not either go to the OR or exert to stay to resuscitate it and just move. Oh, so any more comments?
Arthur?
Yes, please.
I of course agree fully with Boris, but I think that it sadly reflects that we are adapting to the real life scenario. That, as Boris said, everything is kind of more at hand in the resuscitation room of the emergency department, etc. But there really isn't any reason for that. And everything we do in that room, we should be able to do in theaters. And if we had all that in place, the patient could go directly to theater. And while we're doing all the resuscitation that currently is being taken care of in the emergency department or in ITU, we could simultaneously start doing whatever invasive procedure is necessary. So, yes, in real life scenario today, Boris and everybody are right, but I still think we should try to reorganize so that we could bring the patients directly to OR. Also, the modern theaters will have the imaging equipment in place in the OR, as we have heard multiple times during this conference.
Thank you. Thank you.
One small short comment. I completely agree with you. You know what's going on in Israel, in the JCI area? I hope you all still don't meet this animal, but JCI say, please, before you start surgery, open computer, do checklist, do everything. And I try to put patient on the table and start crying, please do not open computer. What is really the reality of many of the countries? I still hope we still didn't meet this animal. This is a catastrophe trauma.
With the words of the coming EVTM president, Boris Kessler, we will finish. Thank you, Maya. Thank you for excellent presentation. We'd like to, I would like to thank first, I would like to thank our colleagues online and here. Thank you everybody for the efforts to come here, for the efforts to listen online. It's available on YouTube and will be available per session. We hope to go to the US to do the panel in Baltimore with Professor Scott and his team. So we will see how it will work. And I would like to thank again the organizing people here, AMCOM, our University Hospital, Machi Carlson for the support, and very importantly, the companies helping us with the sponsorship. Without it, it's impossible. So thank you very much, and no ego, just good clinical care, science, and collaboration. Thank you.
Hallå, tjena.
Ja, vad tycker ni då? Har det varit lyckat?
Suveränt bra. Jättebra, verkligen. Och tack